Just a while, doctor. Yeah, yes, Professor, you could share your screen and.
All right. Can you see my screen?
Yes, yes. Perfect.
Perfect. Thank you very much. Thanks very much, Dr. Nanduri, for this nice introduction. It's truly a pleasure to be talking to you. Good evening, I guess, for our audience in India, and good morning for Dr. Tumala in Flint, and anyone who's in Michigan area. So I'll be discussing imaging of inborn error of metabolism. I have no disclosures. So anytime you're having an MRI with suspected case of inborn error of metabolism, you feel yourself looking at something like this, a big puzzle, and very hard to understand. Once you're able to solve the problem, you feel yourself you're about to scream. It's really challenging. These cases are not easy. And actually, I was a little bit surprised that you picked up this topic. It's intriguing, but it is always challenging, even for subspecialized individuals in neuroimaging. The reason, it's a large group of disorders we're talking about here. Inborn error of metabolism is more than 500 different disorders that involve failure of metabolic pathways. This is inherited or can occur mostly as spontaneous mutations. Having an approach to evaluate this disorder is confounded by multiple challenges. It is very well known that multiple enzyme defects, different defects, can result with the same or a similar clinical phenotype, which create a huge clinical challenge for our clinical colleagues. Additionally, there is the same disorder can result in variable forms which related to the same enzyme defect, which will result in an overlapping symptoms at different ages, for the patient themselves. As having a classification system reflects the knowledge of its time, and this is always an evolving process. So one of the ways to approach these disorders is by looking at where is the process of pathophysiology. These disorders can involve different structures in the cells, that is the lysosomes, the peroxisomes, or the mitochondria that exist in the cells, resulting in abnormal accumulation of different substances. Or it could be related to a defect in one of the metabolic pathways, resulting in the aminoacidureas. A subtype of it is urea cycle disorders. It can result in organic acidemias or other disorders, just like glycogen storage disorders. So that is the where. How about looking at a different way of classifying these disorders? What is happening? What is the pathophysiology of these processes? These can be divided into disorders that is exclusively or dominantly involving the gray matter, or what is known as the polydystrophy. Or we can look at them as these disorders that have predominant white matter involvement, known as the leukodystrophy. Pathophysiologically, there are different pathways to have such results, starting with lack of myelin deposition, such as in hypomyelinating leukodystrophies, or loss of myelin and deposition of structurally abnormal myelin in the leukodystrophies, demyelinating and dysmyelinating leukodystrophies. And finally, we can have what is known as vacuolization in leukodystrophy with myelin vacuolation. A recent article from Van der Knaap in 2017 added several other pathways for these disorders. This can affect any component within the white matter. It can affect the astrocytes, resulting in what is known as the astrocytopathies. It can affect the microglia within the white matter, resulting in the macrogliopathies, or it can affect the axons in what is known as leukoexynopathies. And finally, it can affect the vasculature, resulting in what's known as the leukovasculopathy. And finally, you can have disorders that can affect both the gray matter and the white matter, or disorders that is most dominant involving the brainstem and the cerebellum, and sometimes involving with or without involvement of the spinal cord. Then we can look and classify these disorders based on how the clinicians evaluate them. When the clinical presentation, and how is the clinical presentation? This can be during the newborn period. This is usually is associated with urea cycle disorders, amino or organic acidemias, or it can be seen in the early infantile period. It's typically mitochondrial, urea cycle, amino or organic acidemias. Patients presenting late in their late infancy, during the childhood, juvenile, and adult period, you want to think of a different set of disorders that's predominantly lysosomal, mitochondrial, or peroxisomal disorders. Obviously, none of this works, and we want to think of more strategic approach. And to be honest, you really have to have a combined approach where you have the clinical information, the laboratory data, and then you supplement all of this with your imaging findings. What do you see on CT scan? What do you have on MRI? And whenever possible, you want to perform MR spectroscopy to help to narrow the differential diagnosis. So starting with our CT and MR imaging findings, you want to assess two things. Where is the location of the brain abnormality, and what is the pattern of the brain abnormality? Location, is it predominantly involving the white matter, or it's involving the gray matter, or there is involvement of both the white matter and the gray matter? And then you want to evaluate the lobar involvement. Is this something that is frontal predominance or parieto occipital predominance? And then within the white matter, what is the area that is being involved? Is there the involvement of the periventricular, the subcortical, or the juxtacortical white matter, or this is a diffuse process, but this is typically seen at later stages of these disorders? Is there evidence of basal ganglia and thalamic involvement? Is there involvement of the brainstem and cerebellum? And finally, what is the condition of the corpus callosum? And then we can evaluate the pattern of these abnormalities. You want to first and most importantly decide what is the myelination like. Is it normal, or is it delayed myelination? The pattern of these disorders, is it symmetric, patchy, confluent, or does it have a vague borders? And then if there's a mixed pattern between patchy and confluent lesions, the appearance, is there evidence of brain swelling or brain atrophy? And then very importantly, sometimes to assess for the presence of parenchymal cysts. Presence of calcifications is very important. We can clearly see them on MRI. CT scan is way easier to assess for the presence of calcification. However, susceptibility weighted images can help us in this characterization and assess for the presence of calcification of hemorrhages. Generally, we give contrast material, and it can help to narrow the differential diagnosis, as we will see in some of the coming examples. So before we start with what is abnormal, we need to decide what is normal, and more importantly, to understand the myelination process in the child. This is a dynamic process that progresses in an organized and predetermined pattern that reflects the various stages of the developmental milestones of the newborn or the infant. This reflects his neuropsychological development. General rule that we use is that myelination progresses from caudal to rostral, from dorsal to ventral, and from central to peripheral. These are just important rules that we can use it, and we'll see it in the coming slide. And then we have to remember that the normal myelination on progression on the T2 weighted images lags a little bit behind the T1 weighted images, and roughly it's approximately 3 to 4 months. General rule, I see it, but I really don't like it a lot, is that myelination is completed on T1 by 12 months of age, and then it is completed and has its adult appearance on the T2 by 24 months of age. However, keep in mind that, we still have what is called the terminal zones of myelination that is typically seen up to 3 and 4, sometimes in 5 years of age. So keep this in mind whenever evaluating the brain of young children. These patterns are sometimes challenging, and I have to admit it, that I do search Google for myelination atlas. I just, there are several websites online present, and whenever I'm having a pediatric patient with suspected hypomyelination disorder, I always check the myelination atlas just to be sure that I'm looking at something normal or something that is abnormal. So here's the, the normal pattern of the myelination milestones. This starts very early in during development. As a matter of fact, it starts by 32 weeks of gestation with myelin laying in the brainstem. We see very little amount of myelination in the supratentorial brain parenchyma. It rapidly evolves over the next weeks, and by birth, we will see evidence of some myelination within the internal capsules, specifically in the posterior limbs. This can be seen here on the T2 weighted images. You can see there's a wisp of dark signal on T2 weighted images, and then on the corresponding T1 weighted images, we see a very subtle T1 signal changes. As the child will evolve, their ability to do things will be increasing, and by 4 months of age, the myelination has increased. You can see that just subtle wisp of dark signal in the T2 weighted images got larger. It is better defined now on the T2 weighted images. On the T1 weighted images, we see a larger area of myelination. The subtle T1 signal involving the internal capsule started to spread into the external capsule. Now, again, as I mentioned in one slide earlier, the myelination on T2 lags approximately by 3 to 4 months on T1 weight compared to the T1 weighted images. So you can see on the T2, there's still a lot of bright signal related to unmyelinated white matter compared to the T1 weighted images, where you can see larger areas of what is representing a myelinating white matter. Later, by 7 months of age, the myelination has progressed. You can see all of these bright signal involving the corticospinal tracts. Now we have myelination within the splenium of the corpus callosum and the genu of the corpus callosum. Realize the difference compared to much earlier, 4 months of age. And then on the T2 weighted images, the myelination has increased, but it is lagging behind as it appears on the T1 weighted images. And again, this reflects the neuropsychological development of the child. This child now is able to turn from his back to his tummy. He is having some strength to his muscles. As with time, the more myelination will be present, and then you can see that on T1 weighted images, by 1 year of age, there's T1 bright signal throughout the cerebral white matter. It progresses again from posterior to anterior. Realize on 7 months of age that the myelination is better seen in the posterior parieto-occipital regions compared to the frontal regions. By 1 year of age, the myelination will be completed on T1 weighted images. On T2, it's still lagging behind, but realize that the parieto-occipital regions have a more myelination compared to the frontal regions. This reflects what the child is able to do. He's able to see you, he can understand, he can realize who you are, but he cannot understand, more complicated things related to the frontal lobes. By 2 years of age, the myelination will be completed on the T1 and T2 weighted images, keeping in mind that there are subtle areas of what we call the terminal zones of myelination. These areas of subtle bright signal in the juxtacortical white matter, typically seen in the frontal and temporal lobes, and sometimes seen in the periatrial white matter. So with that in mind, let's have some approach to these disorders, combining both the radiologic findings and the clinical findings. So we have what is known as the hypomyelination leukodystrophy, with macrocephaly. This is very important clinical feature that will help us to narrow the differential diagnosis as we're dealing with a short list of disorders. And then we have these disorders that have a normal head size. And then again, we can benefit from the clinical presentation. Is this an acute encephalopathy? We want to think of mitochondrial or amino-organic acidemias and urea cycle disorders. Or is this a chronic progressive process? Then you want to think of mitochondrial, lysosomal, or peroxisomal disorders. Now, I'm sorry, there is the line here, this red line. I don't know how it appeared. Any ideas, Dr. Nandouri?
Yeah, I think it must be your pointer from your...
I did not use a pointer, actually. I don't know. Interesting.
Maybe it just got by accident.
Okay, you guys are okay. I mean, I can stop, and then I'm afraid if I stop sharing.
That's fine. That's not an issue.
Okay. I'll just continue. I'm sorry, I don't know how it appears. Yeah. Anyway, all right. I don't have a pointer though. I have to point to say. So, starting with a hypomyelination leukodystrophy. The signal of the cerebral white matter in hypomyelinating disorders is similar to normal child, but at much younger age. This is a child that is in his 3rd or 4th years of age, but his myelination milestones are similar to someone who's at 1st or 2nd years of age. Differentiating a hypomyelination from delayed myelination can be challenging, especially before the 1st year of age. And as a general rule, we require the patient to come back within 6 months to assess if there is, this pattern of deficient myelination is stable or is it improving, because we want to confirm that are we dealing with a hypomyelinating disorder or a disorder of delayed myelination. So Pelizaeus-Merzbacher disease is the prototype hypomyelinating leukodystrophy. Here's a child who has a respiratory distress. You can see, on the T1 and T2 weighted images, the myelination milestones are normal. This is what we expected around 5 days of age. There's a wisp of dark signal of the posterior limbs of the internal capsule. There is myelination of the anterior anterolateral aspect of the thalami and the globi pallidi. On the T1 weighted images, we see normal myelin in the basal ganglia and thalamus and the posterior limbs of the internal capsule. The kid continued to have, some structural abnormalities with hypotonia. When we imaged him 9 months later, you can see his cortical appearance has evolved. He's developing more sulci and increasing the complexity of his brain surface. However, his myelination milestones has not evolved as expectedly. It is, as a matter of fact, very similar to when he was first born. There is still bright signal of the white matter on the T2 weighted images. And then the appearance on the T1 weighted images, you can see it is relatively dark, very similar to the same patient when he was first born. Realize sometimes there's involvement of the globi pallidi. This is due to a high concentration of myelin in these areas. And then if the process is a hypomyelinating, it will affect the globi pallidi. 18q deletion syndrome is another disorder that is characterized by hypomyelination. Here's a 4-year-old male child with developmental delay and some craniofacial deformities. On the T2 weighted images, we have an appearance that is similar to the previous child, where there is evidence of a hazy, a bright signal on the T2 weighted images throughout the cerebral white matter. On the T1 weighted images, you can appreciate there is some myelin has been deposited, there's some deposition of the myelin, there's a bright signal, but definitely on the T2, there's what we call it a T1, T2 mismatch. So Pelizaeus-Merzbacher disease is the prototype hypomyelinating disorder. This is an X-linked disorder that is characterized by delayed myelination with sparing of the deep gray matter. The exception is sometimes there's a bright signal to the globi pallidi because of the higher concentration of the myelin in this region. Classically, there's no evidence of contrast enhancement. The severity and onset of the disease truly ranges widely depending on the mutation of the PLP1 mutation, which is basically the protein that is responsible for this disorder. Is there evidence of duplication of the PLP1? And this results in a very severe phenotype, clinical phenotype presenting very early, or is this evidence of missense mutation that's typically present a little bit later in life, or is this a null mutation where there is much milder symptoms, and this patient typically presents with spastic paraplegia. Pontine abnormalities are not present in patients with Pelizaeus-Merzbacher disease. However, if we see what looks like Pelizaeus-Merzbacher disease with pontine abnormalities, we want to think of a very close disorder, what is called as Pelizaeus-Merzbacher-like disease, which involves males and females. So the PLP only in Pelizaeus-Merzbacher is only seen in males. PMLD is seen in both males and females. 18q- syndrome is a rare chromosomal abnormalities. These patients has a very classic craniofacial dysmorphism with limb anomalies. The corpus callosum, brainstem, and cerebellum are typically spared. Hypomyelination with atrophy of the brainstem and cerebellum, just like the name tells it. There's a hypomyelination, bright signal on the T2 weighted images. Realize the signal intensity on the T2 is very hazy. It's really, you're looking at a child at its early development. And then the other part of this abnormality, there is marked atrophy of the basal ganglia, hence the name, hypomyelination with atrophy of the basal ganglia. And then there is atrophy of the cerebellum. So these patients present with, these clinical triad of hypomyelination of the basal ganglia and cerebellum. So a differential diagnosis for patients with suspected hypomyelinating leukodystrophy is prematurity. You just want to be sure that are you dealing with a premature child that was born at 32 or 34 or 36 weeks of gestation. These are kids that are 4 to 6 or sometimes 8 months behind someone who was born at full term. So you want to be sure that you're not dealing with a premature baby, and then you want to be sure that you're not dealing with a delayed myelination related to external stress. It can be it can range from cardiac disorders, or even a simple malnutrition that results in hypomyelinating changes in the brain. Patients who are undergoing chemotherapy will also have a delayed myelination. And this is why we want to bring the patient back in 6 months to confirm if this is a static process or the myelination is progressing, indicating it is just a delayed myelination. The primary hypomyelination syndromes, we talked about Pelizaeus-Merzbacher disease, 18q- syndrome, and 11q- syndrome are two other disorders that present with hypomyelination. And then we have the hypomyelination with atrophy of the basal ganglia and cerebellum. Patients with hypomyelination and congenital cataracts, these are classically presenting with ocular abnormalities, and then sometimes we have the hypomyelination with hypogonadism, that another disorder that presents with hypomyelination. Remember that many other leukodystrophies can present initially as a pattern of hypomyelination, many mitochondrial encephalopathies, or the lysosomal leukodystrophies can present itself early on as a hypomyelinating disorders. So the other set of disorders that we can benefit from having some clinical history is leukodystrophies with macrocephaly. So these are the kids that have a big head. Here's a brain MRI of a child with macrocephaly and psychomotor delay. There's extensive abnormal signal, very confluent. You can see predominant involvement of the frontal lobes extending to the, to the subinsular regions. There's also involvement of the anterior temporal lobes. Basal ganglia is involved with some abnormal signal. And then when we give contrast material, there is evidence of nodular enhancement within the condylothalamic groove and outlining the ventricles. These areas of abnormal signal has the relatively dark signal on the T2 weighted images. And this is an example of Alexander disease. Pathologically, this is an astrocytopathy process related to mutation of an astrocyte-specific gene products. This is it results in accumulation of the GFAP or Rosenthal fibers, and this will result in a cascade of injury to the astrocytes, which will result in this appearance. This is classically seen in infantile, during the infantile period, with a frontal predominance along with involvement of the basal ganglia. How about this child? He's presenting much later in life. He is a juvenile with having what we call the juvenile onset Alexander disease. There's a shift of the distribution of the abnormalities from having frontal predominance. Now we're having a involvement of the posterior fossa with lesions around the brain stem. This is classically presenting with bulbar or pseudobulbar symptoms. Patients present with extensive vomiting. When we give contrast material, these lesions will show some enhancement, and this is the juvenile onset Alexander disease. In contrast to the kids of infantile onset, the head in these patients can be normal cephalic. So this is a disorder that is related to mutation of the GFAP gene with resultant Rosenthal fibers accumulation. There's, as we mentioned, anterior gradient of the abnormalities within the infantile cases. However, later presentation has a predominant involvement of the posterior fossa structures, which will be reflected in the symptoms, these patients having bulbar and pseudobulbar symptoms. And then we will see intense enhancement whenever we give contrast material. Another disorder that is having a macrocephaly. I'm sorry, I did not even touch the screen, and this is appearing. I have no idea why these happening, but again, do you want me to stop this for a second and see if I can get rid of them?
Yeah, please. You could.
Yeah, here, I will stop it for a second and reshare again. Let's see.
Yeah, sure.
Okay. Yeah, I'm not even, I don't know how they are. Okay, yeah, sorry.
Maybe you could close it and reopen that.
I am actually, that's here, this. Okay, can you share? Can you see my screen now?
Yes. Yeah, it's gone now. Yeah, please go ahead.
Yeah, I'm sorry. I don't know why this is happening. I don't even have my my pen turned on. So, okay. All right. So we talked about Alexander disease. So moving to another disorders that have macrocephaly. Again, we benefit from knowing this very simple knowledge by, because we have a very short list of disorders that can present with macrocephaly. This is a 3-year-old child with megalencephaly, severe mental and neurological deficits. There's extensive abnormal signal. You can see all of this is seen throughout the entire cerebral white matter involvement, including involvement of the juxtacortical U fibers. There's extensive involvement of the basal ganglia, and there's involvement of the brainstem and the cerebellar white matter. And this is a case of Canavan disease. This is the time when we want to do MR spectroscopy, and it is one of the few examples where MR spectroscopy is truly helpful. Most of the time, MR spectroscopy will have non-specific features with, some indicating this injury to the white matter. But in Canavan disease, the pattern is very classic. This is a leukodystrophy where the NAA is there's failure of metabolizing DNA, resulting in excessive accumulation of DNA, which will result in a vacuolating injury to the cerebral white matter. DNA is markedly elevated compared to the choline and creatinine, as you can see at 3 level, 3 and 3.2 parts per million. So another disorder that is presenting with macrocephaly is megalencephalic leukoencephalopathy with subcortical cyst. This is another astrocytopathy. The pathophysiologic process appears at the level of the astrocyte with intramyelinic vacuolation. Classically, they have extensive T2 signal throughout the cerebral white matter. You can see there's evidence of cyst formation. The MR spectroscopy is very non-specific. There is just, low NAA. Classically, the NAA is much larger compared to the creatinine and the choline. Here's the sagittal T1 weighted images. You can see there's apparent enlargement of the cranium compared to the face. So this patient have a macrocephaly. In the differential diagnosis is the another disease, that is more common, that presents also with extensive white matter abnormalities with subcortical cysts, classically in the anterior lobe, that is congenital CMV infection. Keeping in mind that this disorder has a different clinical phenotype. These patients are micro or normocephalic, and classically they present with sensory neural hearing loss, helping us in differentiating, these two disorders. So patients who have leukodystrophy with macrocephaly have relatively short differential diagnosis. You want to think of Canavan's disease. These classically have markedly elevated NAA on MR spectroscopy, or you can think of Alexander's disease. These present with intense nodular enhancement and macrocephaly in its infantile onset disorder. And then we can have megalencephalic leukoencephalopathy with subcortical cyst. And finally, L2-hydroxyglutaric aciduria. These patients classically have early involvement of the juxtacortical white matter. So I just put this slide, to explain a little bit of the MR spectroscopy and how it's read. This is just, very short look into it. Clearly, there are a lot of references to in the literature to how to read these the MR spectroscopy. So on the X direction, this is the frequency or the position. It is read by, this is parts per million. And then on the Y direction, we have the peak height, which reflect the concentration of the different metabolite. The largest of these metabolites is seen at 2.1. That reflects the NAA. This is there's abundant of NAA in the brain, and there are two smaller peaks noted. The one seen at 3.0 part per million reflects the creatinine, and then there is a smaller peak at 3.2, that is the choline. Then there are all of these little peaks existing everywhere around 0.9 to 1.1. There's the lipid peak, and then we have couple peaks related to glutamine, that's around 2.2, 2.4, and then there's a second peak for it in around 3.8 parts per million. Now, a general rule that we use to read MR spectroscopy is what is called as Hunter's angle. If we draw a line connecting the tips of the NA, creatinine, choline, and the myoinositol, there is, this line has approximately 45 degrees angle, and this is what is expected in normal MR spectroscopy. However, kids with abnormal, spectra will have abnormal Hunter's angle, as we saw earlier in the example of the child with Canavan disease or the megalencephalic leukoencephalopathy. All right. Then we're moving to, disorders that have normal head, and then we can again benefit from the clinical presentation. We need to ask, is this patient presenting with an acute encephalopathy, or he's having chronic progressive clinical presentation? In acute encephalopathy, majority of disorders are typically seen involving the gray matter. This is a poliodystrophy. This is an example of methylmalonic acidemia. Realize there is an abnormal signal involving the bilateral globi pallidi extending to the midbrain with involvement of the cerebral peduncles. On the diffusion weighted images, there is restricted diffusion in these areas. Later on, there would be volume loss with gliotic changes and lack of restricted diffusion. The MR spectroscopy, you can see there's evidence of relatively low NAA peak. The Hunter's angle, based on the Hunter angles, the peak should be somewhere around, here, and we can normally draw the line at the 45 degrees angle. This is relatively low NAA peak, and then there is a duplet at 1.2. This is reflecting accumulation of lactate in the brain. This is abnormal at this age group. Early on, around in the first few days, you can normally sometimes see lactate in the brain. So organic acidurias is a heterogeneous group of disorders that is characterized by excretion of organic acids in the urine. There are three main clinical presentations for these disorders. One is severe neonatal onset, that is present with metabolic distress, or an acute intermittent, typically at later age group. And then finally, we can have a chronic progressive form that is presenting as hypotonia with failure to thrive and developmental delay. Majority of patients who have organic aciduria will have abnormal signal of the basal ganglia, and depending on the stage of the abnormality, you can have diffusion restriction. However, again, in the chronic stages, there would be no evidence of restricted diffusion. Patients with glutaric aciduria type 1 will have widening of the Sylvian fissures, and then L2-hydroxyglutaric aciduria and glutaric aciduria type 1 has classically large head size. Here's our patient with methylmalonic acidemia. You can see abnormal signal classically involving the globi pallidi with restricted diffusion, compared to patients with propionic acidemia, also presenting with abnormal signal of the basal ganglia, but classically seen in the neostriatum. This involved the caudate nucleus and the globus pallidus with evidence of restricted diffusion. So both of these disorders, as well as many other organic acidemias, classically involve the basal ganglia. Glutaric aciduria type 1 similarly will have extensive abnormal signal of the basal ganglia with restricted diffusion. However, we can sometimes see involvement of the white matter. These patients classically present with big head, and you can see there's evidence of enlargement of the extraaxial spaces. Mostly these patients would present with subdural hematomas or subdural effusion, and then classically there's abnormal widening of the sylvian fissure. This is very classic for glutaric aciduria type 1, and we want to keep it in mind whenever we are dealing with suspected child abuse, because it comes quite often as a possibility in these kids because of their because of the presence of subdural hematomas. L2 hydroxyglutaric aciduria is another organic aciduria disorder. These kids present with big head as well, as we indicated earlier, but classically there is abnormal signal that starts in the juxtacortical white matter and then progresses centrally toward the subcortical white matter. You can see of the sagittal T1, this kid has a relatively large head compared to his facial size. Now, moving from our organic acidurias to another disorder that present acutely is, aminoacidurias. These are classic pattern. A classic disorder is maple syrup urine disease. This is a 1 week old with irritability, poor feeding, and lethargy. These patients present with extensive abnormality, what we call MSUD edema, where there's evidence of extensive restricted diffusion of what is representing the myelinating part of the brain within the parts of the corticospinal tract. In the basal ganglia, realize there's involvement only of the globus pallidus and thalamus. These are the parts that are myelinated at this stage, and there is also abnormality of the brainstem and the cerebellar white matter. This is the myelinated part of the brain at the early stages. On the corresponding T2, there's extensive edema in these regions. And then elsewhere, there is evidence of edema, but this is not as extensive as the involvement of the myelinated parts of the brain. So amino acid disorders, also called as aminoacidopathies, are related to a defect in the metabolic pathways of the amino acids. Patients present initially well and then become acutely symptomatic after a period of protein feeding or recent infection. This is basically metabolic decompensation that they are having. MSUD is an autosomal recessive metabolic disorder that affects the branched-chain amino acids. And then in neonatal MSUD, this is associated classically with diffuse characteristic brain edema. What is, as I mentioned, is the MSUD edema, where there's evidence of vasogenic edema involving the unmyelinated white matter. And then we have a cytotoxic edema involving the white matter in the distribution of the basal ganglia, brainstem, and the cerebellum. That's the myelinated part of the brain in young age group. Urea cycle disorder is another amino acidopathy. These patients classically present with restricted diffusion involving the subcortical white matter and the basal ganglia. There's classic sparing of the thalami, which is, helps to differentiate urea cycle disorder, a disease that presents early in life, compared to HIE, hypoxic ischemic encephalopathy, which have a similar imaging pattern, but also will have, involvement of the thalami as well. MR spectroscopy will show a very large lactate peak, non-specific imaging feature indicating, there's abnormal metabolite being accumulated. Realize the NA is low. However, this is very limited. In young children, the NA is relatively low because there is no myelination present yet, and the NA will normalize and have its adult form around, I would say, 6 to 8 months of age. That's the time when the NA peak will be larger than the choline and creatinine peak. And here's, you can see there's a markedly elevated glutamine and glutamate peak. This is related to the urea cycle disorder. When urea cycle disorders present at later in life, they will present acutely. With markedly elevated ammonia level. There's extensive restricted diffusion involving the cortex. These are the eloquence part of the brain, and it is, in the differential diagnosis of the HIE, we want to seek for that history. On admission, this patient had an ammonia level of 250, which is twice above the normal level. The differential diagnosis for urea cycle disorder is hepatic disorders. Patients with cirrhosis can present with acute encephalopathy. They will follow the same pathway where there's marked elevation of the ammonia, and they have a similar involvement of the cortex. This is cytotoxic injury related to marked elevation of the ammonia with accumulation in the brain. Not all patients with aminoacidopathies will present acutely. Phenylketonuria is an example of patients who present with non-specific features. There are patchy signal changes classically seen in the periatrial white matter, but they can involve other parts of the brain. Patients sometimes with aminoacidopathies can present with the chronic progressive clinical presentation. And finally, moving to our last category, which is the chronic progressive encephalopathy patients. This is classically patients with lysosomal disorders. Here's a patient with metachromatic leukodystrophy. You can see in the classic imaging feature, extensive diffuse T2 signal involving the cerebral white matter, relative sparing of the basal ganglia. There is what we describe it as being striated pattern. However, keep in mind that this is not specific to metachromatic leukodystrophy and can be seen in other disorder. This is an autosomal recessive disease caused by mutation in the aryl sulfatase gene and results in demyelinating injury to the cerebral white matter with oligodendrocyte injury. There are three major subtypes depending on the age of onset, and then the most common presentation is having a parieto-occipital dominant in early infantile cases, but there's frontal dominance in later presentation. Krabbe's disease is another lysosomal disorder, typically present with hazy signal on T2 signal on the imaging. With involvement of the white matter and the brainstem and cerebellum. And then these patients also have this enhancement of the cranial nerves. This is another autosomal recessive disorder, and these patients present very early in life. There's abnormal signal in the cerebral white matter, and then on CT scan, we might see mineralization in the thalami. This here is X-linked adrenoleukodystrophy. This is the most common disorder of inborn error of metabolism in the brain, typically seen in male patients. However, keep in mind that 20% of female carriers will be affected by these disorders. There are three main phenotypes that is seen in these patients: a cerebral adrenoleukodystrophy. This is typically seen in young patients, compared to the second phenotype, the adrenomyeloneuropathy, which is typically present later in life. And then patients sometimes will have symptoms of adrenal dysfunction with Addison's disease only. That will be presented later. Classic imaging appearance is abnormal signal in the periatrial white matter, and then there is evidence of abnormal enhancement in the periphery. This feels like it is torched brain, where the injured brain is already gliotic, and then the active demyelination process is having some enhancement. This is just a slide to remind us of the disorders that present with calcifications: Aicardi-Gouttieri syndrome, cocaine syndrome, cystic leukoencephalopathy with megalencephaly can present itself with calcification, leukoencephalopathy, calcification, and brain cyst. Just like the name says, you will see white matter changes with calcification and cyst. Lebrun disease, other mitochondrial diseases like MELAS and Kern's-Sayre disease, all of these will present with brain calcification. But keeping in mind, a great mimicker, CMV, can present itself with brain calcification. So just, all of these, what we talked about, when we approach these disorders, we need to characterize the MR imaging features and decide for ourselves, is this a hypomyelinating disorder that we're dealing with, where there is the signal changes are mild and reflect like you're looking at a young age group, or is it something else we're dealing with where the signal changes are very prominent? The T2 is very bright, and the T1 is very hypointense. In hypomyelination, we have a short list of differential diagnoses depending on the presence of peripheral nervous system involvement. However, in other disorders, we try to decide the preferential involvement, whether there's a frontal predominance or parieto-occipital predominance, or if there is, preferential involvement to the periventricular and subcortical white matter, and then in diseases that present itself with diffuse cerebral involvement. Disorders involving selectively the brainstem and cerebellum has different and relatively short list of differential diagnoses, and here is my list of disorders involving the brainstem. All right, thank you very much. That concludes my talk.
Thank you, Doctor. That was a very elegant presentation. You made it really simple in terms of hypomyelination to leukoencephalopathy with large heads and then progressive leukodystrophies. We have audience from neurologists and pediatricians as well as senior radiologists. I would invite comments and opinions from them as well. Dr. Jagan, if you could start.
Good evening, everyone. Thank you, Dr. Ibrahim, for a very good talk. Actually, this is one of the most complicated, and though we don't, as a general radiologist, we do few cases now and then, and we always keep books to run through them. My basic question is, like these pediatric children, we will be doing under anesthesia. So whatever the study we are doing, we should be extremely careful. So I just want to know the protocol, whether we can do CT at the same time, whether contrast to be given and MR spectroscopy to be done. And if not, which cases to be selected for contrast and spectroscopy, which cases should not be selected?
Certainly, that's a very good question. Actually, it's amazing. I did have my slide of our protocol, and then I thought, you know what, probably nobody needs it, but I'm surprised that the first question indicating that I should have left that slide on our protocol. So, but thank you. That's a very important question. So, answering your question, obviously, imaging children is very challenging, and we need to have to be determined how we approach these cases. When I was a fellow at Sickkids Hospital, we QC'd every case, every pediatric patient. We will walk to the machine and will QC the case and decide whether we will give the contrast or not, or obtain further imaging. Obviously, this is not practical in busy settings. Where I work right now at Mott Children's Hospital, we don't do that. We just give contrast material to all of the patients. Now, for the second part of your question, deciding about obtaining a CT scan, I think there is a lot of information in the MRI that will suffice to, to not to do the CT scan at the same time, especially with SWI images. It has a specific information that can help us to assess the calcification and differentiate calcification from its, another abnormalities that can be seen, like microhemorrhages or, I think there's enough information on the SWI images that can help to differentiate between these two processes, basically. So I don't think CT scan is required in all of these patients.
Oh, thank you.
You're welcome.
Thank you, sir. Thank you very much.
Yeah, any other comments? You have a neurologist, Dr. Rukmini. You want to add something? Or?
Hi, sir. Thank you. That was a really nice talk. It was always difficult for us actually to get it. I think there's a lot of noise in the background, but I really enjoyed the talk. Thanks again.
Thank you, Dr. Rukmini. Any other pediatricians too are there? Any comments or questions, queries from them? Dr. Ibrahim, if you could see the chat box, there are a couple of questions for you.
Sorry. Okay, yeah, you're right, actually. Sorry, here, let me just differentiate severe periventricular leukomalacia versus vanishing white matter disease. That's the first question is how to differentiate severe periventricular leukomalacia versus vanishing white matter disease for MR spectroscopy in inborn error metabolism. Where should we keep the voxels? Okay, so the two questions from the same person. So obviously, vanishing white matter disease is common and, well, not common, but, we see it frequently, and it presents itself very similar radiological picture to the, patients with, chronic changes from HIE. Obviously, the history is very important here when, we can acquire the history from the clinician to find out if there's evidence of HIE injury that will result later in periventricular leukomalacia compared to patients with vanishing white matter disease. This is a progressive process that will, present itself at later stages as PVL, but have a more progressive course. Now, as far for the location of the MR spectroscopy, we do both the basal ganglia with short TE and long TE, and then we do the centrum semi-valley white matter with long TE. So if we have the luxury of time, we will do 3 MR spectroscopy, 1 in the basal ganglia using short TE and long TE, and then in the centrum semi-valley white matter. The second question says Canavan, but I'm not sure what was the rest of the question. Metabolite ratio cutoff to differentiate neoplasm versus non-neoplastic lesions or different grades of neoplasms. This is very important question. Obviously, it's not the topic of our discussion, but to answer it, we do not trust the metabolite ratio. Generally speaking, MR spectroscopy unfortunately has fallen out of favor in the recent years in helping to, evaluating the neoplastic process. That being said, there are several papers. I think one of the very good papers is by blanking, sorry. It's in the AJR. There's an AJR paper. I'm completely blanking on that paper, but it is a good paper to for these ratios. Actually, I always read it to use it for to differentiate to help out differentiating neoplasms versus radiation necrosis. That's the most common actually usage for it. For neoplasms, whether it's a low grade or high grade, I never trust it, especially in pediatric patients. Pilocytic astrocytoma, a very grade 1 tumor, can have a very malignant appearance on MR spectroscopy, and then medulloblastoma can have a non-specific MR spectroscopy. So I never trusted in pediatric. The next question, kindly repeat how to differentiate urea cycle disorders from HIE. Certainly. HIE, in the severe form of HIE, we will see abnormalities involving the cortex and the basal ganglia, including the thalamus. Urea cycle disorder will classically spare the thalamus. So the thalamus is being spared in these disorders. And this is, something that will help to differentiate between urea cycle and HIE. Where can I see the recording? That's Dr. Nanduri will decide where to see it. Dr. Tumala, thank you for very detailed, comprehensive demonstration of complex subject. Thank you, Dr. Tumala. And then the final question, recording will be uploaded shortly. Okay, all right, that's you, I guess. All right, that's any other questions?
I think that was a very comprehensive, and you made it really simple, even for general radiologists like us. I think you created a what you call a roadmap or algorithmic approach to the whole picture. I think that's very useful for all of us to go ahead when we deal the next case on MR, whenever you find that.
Great, thank you very much. This is really a very difficult topic, and I'm impressed that you wanted to deal with it. It tells a lot, actually. It tells us that you guys are, willing to take challenging cases. I'm glad I have, such an audience. It was really a great honor to be here. I'm glad that you guys enjoyed the talk.
Once again, my regards and thanks to your colleague, Dr. Rajiv Bapuraj, for having facilitated this presentation. Sincere thanks from KREST Hyderabad, India, for you to readily accept the program and be a part of this. We'll be uploading the webinar shortly. We'll send you the link as well. We hope that you once again participate as a speaker sometime later in the year at your convenience on a much more challenging topic. We look forward, Professor Mohannad. Sincere thanks and good day and good night to all of you.
Thank you. Thanks very much.
Thank you. With your permission, I'll close the session.
Absolutely. Thank you.
Thank you so much.
Take care.